observe in these fictional characters without saying the words antisocial personality, because I think it's pretty much obvious of what this movie's about. And I'll bring it up because you've got to learn it, and it'll be on the shelf exam. But we're going to opt to say that this movie is not about antisocial personality because it obviously is, and you'll be here every week saying the same thing, and I'm not. If I teach you the same thing 5 consecutive Fridays, is focused on Pulp Fiction. So for the group, any particular character you'd like, where you'd like to start? No wrong answers. Meaning that anything you say is correct.
We can start with the main character. I forgot his name. The guy. Yes. Yes. Yes, Barry, what of that? I know that we're not supposed to mention this, so we're psychotic. That was one thing that I couldn't really think of.
So let's say that he actually demonstrates a blatant disregard for and violation of others' rights, right? So violating others' rights. And let's say that is, in fact, the reason why he comes to your clinical attention, whether it's an outpatient office, whether it's a consult service. What might be some things you want to inquire? We'll call it the prequel.
If symptoms began before age 15.
Right. And let's say that there is no evidence of, I would suggest that you're looking for conduct disorder.
Mm-hmm.
There is no evidence of conduct prior to the age of 15.
Well, one of the things that's interesting is like contextually, his behaviors were sound. You know, like it was like watching it, you're like, this is wild, you wouldn't do this in real life. But he wasn't in like every day of real life. It was like in this situation where everyone around him was acting this way as well. And it was in some ways culturally sanctioned.
Mm-hmm. Yep. I think there's a lot to that. And that'll come up on exams for you. I think the most recent one would be your shelf exam. And this does default to a discussion of culturally sanctioned behavior. And you're going to have to differentiate those behaviors from culturally bound syndromes. And in the first line or two of any vignette on a shelf exam, you're going to see a very common feature. So after you read the first sentence or two, choice A, culturally bound syndrome, choice B, culturally sanctioned behavior, you're not going to know the difference yet. So to start out, what will the first line or two of that vignette read? What is the common thread between these two different syndromes or conditions? They're geographically isolated. And that geographical location is not likely to be the U.S., and if it is, it'll be a subculture of the U.S. When you see that, you pretty much know that you're going to be looking for a culturally bound syndrome or a culturally sanctioned behavior. Which one? You don't know yet. When you understand that, and maybe you peek at choices A, B, C, and D, and you actually see that two of them do say each of these answers, and you know you're on the right track, you now know to specifically look for very specific information that's going to lend you or lead you to the single best answer. So for the culturally bound syndrome, what information will you be actively looking for? In a culturally bound syndrome, the information that will buy you the answer and therefore rule out or rule against culturally sanctioned behavior is that in that geographical locale, again, not likely to be the U.S., the behavior is deemed to be abnormal. Hence, culturally bound syndrome, the emphasis here on syndrome. So, again.
I'm thinking like ataque de nervios, but like it's a culturally bound syndrome, but it's still like concerning to the people within the culture too. Like,
correct, that's exactly right. Exactly right. And then just separate those wordings, right? So culturally bound gives away the common feature of being geographically isolated. Syndrome ensures or operationalizes that within that culture, the behavior is abnormal. Now, that would mean that 9 times out of 10, the question writer, the board, is going to want to test your knowledge on the specific names of these syndromes. So you're going to have to learn some of these because that's very likely to be what they're asking. All right, so give me some examples of culturally bound syndromes.
Ataque de nervios.
All right, so what will need to be in place for you to diagnose ataque? Two major things come, probably three really. Number one, it's going to be culturally bound. Where? Where's the geographical location? When I say the full name again?
Ataque de nervios.
Yes. Right? That's number one. Number two, they might spoon feed you and demonstrate that it's resulting in clinically significant distress. In case you haven't gotten the message, that's going to buy the fact that it is in fact syndromal and therefore abnormal in that region. Per the individuals indigenous to that region. In addition to that, it looks like a panic attack. And panic attack might be answer A, skip it, because there's a better answer and you're looking for the single best. And the one aspect of this particular panic-like syndrome that really will buy the diagnosis is the subjective sense of heat that begins in the abdomen and rises to the chest. Right? That's specific to ataque. Any other examples? That is a common one that appears on shelf exams. I would strongly encourage you to go to your favorite board review text. There's always a chapter 2 pages long, just with lists of this. So read through it a couple times. You will need to know at least one, I would think, for your shelf, maybe as many as 2, but I've never seen more than 2 on a single shelf exam. Any questions about culturally bound syndrome? Culturally sanctioned behavior starts out the exact same way. Behavior that is cultural, i.e. geographically isolated. And what's your best guess as to what differentiates this condition, this situation, from any culturally bound syndrome?
This culturally behavior that's abnormal. I mean, normal in them.
That's it, right? Here we're more along the lines of 50-50 in terms of what you're likely to be asked. There's still a chance you could be asked for the specific behavior because these are labeled, right? So hoodoo, H-O-O-D-O-O, hoodoo, otherwise known as root work, is a culturally sanctioned behavior indigenous to the Bayou region of Southeast United States. Spells and magic to cast off evil spirits. If somebody from Louisiana landed at Newark Liberty and began to put down brick dust to ward off evil spirits, Homeland Security is probably going to take them for eval. You're probably going to be on call, and you're going to call me. And our single best answer, our next step would be to release the patient. There's nothing to do. It's perfectly normal. On the other hand, you may be asked that very question. So 50% of the time, figure, I've got to come up with a diagnostic label. I've got to learn these names. But on the other hand, 50% of the time, you may actually be asked, what is the next step? And it's to do nothing. It's to reassure. So that's certainly a question that could be asked.
I don't really know people's cultures and stuff. I guess the best way to.
And collateral. Yeah, and collateral. Mom, dad. Is this something that you teach at home, that you practice at home? If the answer is yes, then there may be nothing to do. Manhattan is a maximum security prison. We see Snake act the way he's acting. I'm not so sure this is any different from somebody from the Bayou region of the southeastern United States practicing root work, northeast United States, behaving the way Snake is for this particular mission that he's on. There may be nothing to see here. But let's say there is, right? Remember, you're gonna start out with this notion anyway, right? Because we just learned that this morning, that your first step in addressing your patient's chief concern is that it is normal until it's not. So let's say that we've uncovered some concerning behaviors, some concerning thoughts in this film nonetheless, and we're now expanding our differential. What else did you see? What else do you want to talk about? What makes you say paranoid?
Just because he's like so on edge, just not very trusting.
And let's say, just for teaching purposes, that you do have evidence, prequel, that this actually persists before he gets that phone call, or whatever it is that he does when he does the mission. So you can't attribute it to the reason why he's in Manhattan. That's what I'm getting at. So we can really expand and be a little creative as to what is really going on here. So there's elements of paranoia. Any thoughts about this? Let's go down this road. What else do you want to know from the patient? What else are you looking for? What did you see?
Snake still, right?
Yeah.
Like the belief that he'll literally blow up if he doesn't complete this task in like 22 hours. You know, outside of like watching them implant that in him, like that'd be like, that's probably delusional or concerning.
I think if a patient showed up in our office with that chief concern, we would think that there might be a delusion and there'd be a physical examination. I think that we would focus our attention to the head and neck region. So I want to rule out delusional. Now, having said this, if in fact upon inspection there's nothing there and we think that this might be a delusion, we now can pair these, right? I mean, your observation that he appears paranoid and there being a delusion are not mutually exclusive, right? So let's talk about the different themes or subtypes of delusion. One, of course, is persecutory, which is exactly what we're talking about. What are the others? And again, these will appear on shelf exams. Different themes of delusion.
Erotomanic.
Good. Yep, erotomanic. I do not think erotomania or the erotomanic type of delusion is being demonstrated in Escape from New York. What would it look like if it were? And do you have any fictional examples of it? I'm basically asking, what is erotomania?
You think someone's in love with you.
Right.
They're probably.
And it's usually someone that the individual has never met. And conversely, someone that the individual doesn't know exists. Erotomania, or the erotomatic theme of delusion. Any movies come to mind? One of the favorites in turn, not necessarily the illness per se, but films that we use to discuss this is Stephen King's Misery. Other themes of delusion.
Insertion. Is that
More specific.
like where like thoughts and stuff getting implanted into your head? I forgot the term.
So thought insertion, otherwise referred to as delusions of passivity. Thought insertion, thought broadcasting being two prominent examples. Not a theme, but certainly a type of delusion. Grandiosity, the grandiose delusion, yes. Just a little iffy for this. I mean,
Might have it.
might have it.
Yeah.
Yep. All right, other themes. So the acronym is JPEGs. That's a hint. And the S is something I thought you were getting at with insertion.
And I kind of mentioned it when I talked about what his delusion.
You did?
I didn't say the word, but that's
Yeah, you did. Somatic. Yeah, good. Thank you. Somatic. Good. I think we have what? One more.
Yeah.
J. Also not necessarily portrayed or demonstrated in this film. Good. Good. Jealous. All right. So again, these are the 5 themes of delusion. Now, an individual often will have elements of 2 or more. So there is a mixed type as well. So be careful on a shelf exam because they might sneak in mixed in letter D. Or maybe none of the above. Sometimes our patients' behaviors don't fit nicely and neatly into these artificial categories that we create for them. So that could be unspecified. There are 3 unspecified delusions that often come up on shelf exams. They go by the name of the person that initially described them. And in one case, it's a little different. Basically, they're proper names. What are these three examples that you have to learn for the shelf? Three examples.
One of them was about aliens.
Or what about aliens?
What do you with?
Specifically?
Was it either that alien did something to them or alien is
I think if the alien was going to come and abduct them, it would be probably persecutory. It's more that the alien has assimilated somebody close to the individual, like their spouse or their next of kin. So it's the imposter syndrome or the body snatcher syndrome, which are not clinical terms. What's the clinical term? Capgras. 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 Two others.
Can you repeat the word again?
Capgras. CAP. Yeah, GRAS. One S.
Maybe I'm wrong.
That would probably fit under grandiose. And even in Stephen King's Misery, again, primarily it looks like it's erotomatic, but there is a scene where Annie Wilkes comes in Paul Sheldon's room and says, God visited me last night. So she's mixed.
Is it for goalie?
So Fergoli is not a clinician. Fergoli was actually an Italian performer who was known for how quick he can change costumes on the side of the stage. Right? So that gives a hint as to what type of delusion we're dealing with and what the content of the delusion is. And it's the shifter syndrome. I'm cursing live stream. Shape-shifting syndrome. Right? That's the Fergoli syndrome. So the delusional belief that an individual can actually change appearances. Right? A condition referred to as intermetamorphosis. Fergoli. And there's one more. The delusional belief. No, that is another delusion of passivity. The idea of reference, otherwise referred to as the delusional misidentification. So I take it back. It's delusional misidentification. It's not a delusion of passivity. Right? Passivity would be thought broadcast, thought insertion. The delusional misidentification is the idea of reference, where there's a real object or real stimulus, but there's a delusional interpretation of it. Right? So it's a two-step process. Yeah, so the Cotard with a C, Cotard. The delusional belief that you are dead, otherwise known as the Walking Dead syndrome, or that some part of you is dying or dead.
How does that like? How do patients face that?
Yeah, so I had a patient with Cotard. I think it was schizoaffective with the Cotard syndrome or Cotard delusion, and she was isolating, and it was very difficult to engage her and get her into groups. And she was put on a day program Monday through Friday. And when I met with her individually, the reason why she would not go into groups was because of the odor. So I thought this was a somatic delusion. But when you talk to her more, it was that there were multiple body organs that were dying, resulting in decay in the odor that she was putting off. And she had that fixed belief that one of her lungs and her stomach was decaying and dying.
I had a patient in forensic who was like, well, I did these things and I was taking this drug because I'm dead. It doesn't matter what I do. I died 3 years ago.
You
All
treat
right.
those with antipsychotics?
Yes. Yeah. And again, there's different contexts in which they can present the clinical practice. One could be as a standalone syndrome, right? So the Fergoli syndrome. And then one could just be a delusion, part of a larger illness like schizophrenia. So that would be the Fergoli delusion. And then, of course, the evidence of conduct. This is a condition that the individual must be 18 years of age or older. It's the only age qualifier for any of the personality disorders. And as part of that, conduct prior to the age of 50. The other condition, which we're not allowed to talk about, which also likely afflicts this protagonist, the antagonist, is post